Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled Pharmacist's Role in Transgender and Gender Non-Conforming Care. We are thrilled to have Dr. Anthony Gerber as our guest who will present. Dr. Gerber is a proud Brooklynite, born and raised in Brooklyn, New York. He received his bachelor's degree in psychology from Pace University and his PharmD from Long Island University. After pharmacy school, he went on to complete a PGY1 pharmacy residency at the New York Harbor Healthcare System, VA, and then a PGY2 in ambulatory care at Long Island University, Brooklyn Hospital Center. Dr. Gerber is currently a CDTM ambulatory care pharmacist at New York Health and Hospital, Coney Island. He has been actively involved in NYSCHP, Royal Counties, and serves as one of the co-chairs for its grassroots advocacy committee. In 2022, Dr. Gerber was elected to the position of president-elect of Royal Counties.
Thank you so much.
Oh, absolutely. I'm so sorry. I just have one more chunk really quick. I'm so sorry. Before we get started, I'd just like to share a few quick points. For those who have technical issues during the presentation, please use the chat option to communicate with the office, and every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. The CE code for this program will be provided at the end of the program. Thank you so much, Dr. Gerber. Take it away.
Thank you so much for the warm introduction. Thank you, NYSCHP, also for letting me present. It is Pride Month, so I think this presentation is really meaningful, especially now. Before we begin, I have nothing to disclose, no conflicts of interest, no financial disclosures for this presentation. The objectives for our pharmacists listening in, we're going to define current terminology with regards to transgender and gender non-conforming patients. I'll also be referring to them as TG and C throughout the presentation, so we'll go back and forth. We're going to discuss monitoring parameters for TG and C patients taking hormone replacement therapy, then design proper medication therapies for those patients undergoing medical transition. Lastly, we're going to investigate the role of pharmacists in transgender and gender non-conforming care. For our technicians, we're going to define correct gender pronouns, recognize barriers to healthcare faced by the transgender and gender non-conforming patients, and examine different medication therapies for TG and C patients. So before I begin the presentation, I want us to really think of something. Many of us may know someone who's transgender or gender nonconforming, whether that's someone in our family, our friends, or even a patient that we might see on our work basis. But truly, how many of us feel comfortable at this current time treating a patient who's transgender and gender nonconforming, meeting their unique healthcare needs? I'm just going to assume not many of us on this call today. And because of that, the transgender and gender nonconforming community faces a considerable amount of challenges and barriers to their quality of healthcare. Many of them report inability to find healthcare providers who are properly trained to treat them. In recent years, there has been a lot of attention focused around transgender and gender nonconforming patients in health. The National Institute of Health in 2010 actually began assessing provider knowledge regards to LGBTQIA patients and their health. Healthy People 2020 actually included 5 objectives that were specifically mentioning TG&C population in their data templates. However, this community has had a very difficult time to this day finding healthcare providers. This could be due to providers' personal bias, lack of knowledge on how to meet their unique healthcare needs. Thus, patients really defer treatment or don't seek treatment. When we think of our profession as pharmacists, a survey was done for TG&C patients that showed 41.6% worry about discrimination by a pharmacist. 52.5% felt pharmacists had very little to no competency in transgender health. Because of this, our presentation today, we're going to really learn about this community and their unique needs so we could better assist them when it comes to their healthcare goals. Now, the Williams Institute in 2016 did a census to see how many TG&C patients there were in each state. The numbers here are listed for the United States as well as New York State in particular. Keep in mind, these figures were done in 2016, so likely they're not as accurate. These were done 6 years ago. In the last 6 years, there's been a huge emergence of media, social media in particular. Things like TikTok, Instagram, Facebook. There are shows now, RuPaul's Drag Race, Pose, that are bringing a lot more awareness to the topic and a lot more acceptance. Because that more people are feeling comfortable to come out, identify as their gender. So these numbers, again, aren't exactly accurate to what it is today, but something to keep in mind nonetheless. In order to really properly understand the population, I think we have to be aware of terminology. So I'm going to go over a few very simple definitions so that we can kind of understand transgender and gender nonconforming care. Our first one is assigned gender. So assigned gender is a gender given at birth. Usually it's based on external genitalia, also sometimes also known as natal gender. There's also affirmed gender. This is a patient's gender identity. They kind of go synonymously. It may not align with their natal gender. Sometimes it does, and sometimes it doesn't. Affirmed gender is a complex development. It's an understanding of one's gender self. That could be psychological, physiological, environmental, sociocultural. All these types of influences really define a patient's affirmed gender or gender identity. Then there's gender behavior. So this is how a patient expresses their gender. This could be through dress, speech, intrapersonal style. And lastly, there's gender roles. These are set by a society. So the society will tell us how a man should act versus how a woman should act. If we look at gender roles that may be archaic to us today, traditional male roles, as we used to know them, were wearing pants, playing with action figures, being the breadwinner, while female roles were wearing dresses, playing with Barbie dolls, cooking, cleaning. We know that those gender roles don't really align today, but society has put those on us. And many people feel like they have to be constructed to that specific gender role, or there's something different, there's something wrong with them. None of these four things that I mentioned here have to align. They could all be slightly different. So for the most part, people have discussed those definitions, people understand. It's when we get into the gender spectrum that there's a lot of confusion. So we have cisgender. So cisgender individuals identify as their assigned gender. So their assigned gender equals their affirmed gender. Then there's transgender. So these are individuals who identify as a different gender than their assigned gender. There's transgender males who are assigned female at birth and identify as male versus transgender females who are assigned male at birth but identify as female. Now, there used to be definitions of male to female, female to male. Those are no longer used today due to the stigma. So when we talk about transgender males in medicine, we'll refer to them as assigned female at birth, or AFB. And we talk about transgender females, we can refer to them as assigned male at birth, FMB. So gender nonconforming is where the black and white kind of gets mixed in. It's individuals who don't express their gender in cultural or sociotypical ways. Going further into the gender spectrum, I've listed here the 6 most common genders on that spectrum. The last I checked, I think there are about 64 different genders on the spectrum. When we think of gender, for the purposes of our understanding, let's commonly think of a line. On one side of the line is male, and on the other end of the line is female. So when we talk about these genders on the spectrum, maybe it'll help understand them if we think of this line. So let's look at agender. The individual doesn't identify as any gender. They're gender neutral, null gender, genderless. For the purpose of this presentation, let's say they fall off the line. They're not on the line at all. They identify as something off of it. Then there's gender fluid. These are individuals who shift between social expectations of gender. So individuals who are on the line, but move back and forth at different times of their life. There's androgynous or androgyny, which are defined as both masculine and feminine or something in between. So think of these people are on extremes of the line, but not fully male or female, something really in between, but identify as both. Intersex, which is discrepancy between inter or external genitalia. There's aleogender, which they don't really fit into the existing gender constructs. And then there's non-binary. These are people who don't really experience gender within societal limitations. When we think of non-binary, go back to our line. These are people who are not on the line. They might be on further extremes than the male and female. So they're kind of off. They make the line slightly bigger. This is really confusing at the end of the day. And it's not our job to understand different genders. on the gender spectrum. It's not our job to really fully compare them or understand the definitions. However, it is our job to recognize them and respect them for our patients. We want to make a patient's experience the most gender inclusive and comfortable experience to them. At the end of the day, each individual, you and me on this presentation, should have the ability to select their name, their label, or their not label for their identity, and their gender pronouns. So I'll give a really quick example of this. I was born Anthony Michael. That's my given name by my parents. But to me, the name Anthony always represented me being scolded by my parents, or if I did something wrong in school, the teacher would yell at me and say, Anthony. So I began to call myself Tony, and my friends and my family called me Tony. And it was a more comforting experience when people referred to me as Tony than when Anthony, because Anthony to me felt like I did something wrong. Society, my friends, family never batted an eye to it. Tony, it is. So why should it be different for any transgender or gender nonconforming patient who wants to identify as a certain identity? It shouldn't be. At the end of the day, they're just selecting their identity and how they feel. And we should respect that. To start, let's go over pronouns. So pronouns are based on a patient's preference. Just because a patient had one pronoun the first time you saw them doesn't mean they have the same pronoun today or the next time you see them. Gender identity varies at different stages of a patient's life. And really that's a lot because of social stigma, societal stigma, interpersonal stigmas. So each time you see the patient, ask. Normalize the interaction so it's nothing awkward and so the patient feels comfortable. So I say something when I see patients. Hi, my name is Tony. I'm a pharmacist and I use he, him pronouns. Can you tell me about yourself? When I see them the second time, I say, last time we spoke, you were using she, her pronouns. What pronouns are you using today? This makes the patient feel seen, feels that you're recognizing them as an individual, ready to meet their unique needs. Here are some gender pronouns. There's definitely more. He, him, his, she, her, hers, they, them, theirs, they, here, hers. These are really the most common ones. At the end of the day, take your time, learn a patient's correct pronouns. It doesn't take a lot, but it does mean a lot. So there's also a lot of confusion between the idea of sexuality and gender identity. And what I do want to point out is sexuality and gender identity are not the same concept. Okay? You can be a straight, gender fluid individual. You can be a gay, non-binary individual. These two things are not the same. And to really illustrate that, I have my friend, the genderbread person. Now, this person actually got a lot of media coverage recently, particularly in Florida. But the genderbread person is a great way to really educate ourselves and other people about the differences between gender identity and sexual attraction, as well as gender expression. So if we look at it, there's 4 areas. So there's gender identity that comes from the brain, how you identify yourself. There's gender expression, right? That's the bread's body. It's how you express that gender, whether that's masculine, feminine, something in between. Biological sex is what you're born with. So the genital organ that the patient's born with. And then there's sexual attraction. So are they attracted to males, females? Are they attracted to gender non-binary patients? That's completely different than their gender identity. And many times sexual attraction, romantic attraction can be different. Again, it's not our job to fully understand that, but it is our job to respect it and ask the proper questions. A lot of what we know in TGNC patients, and when we think of kind of these neurobiological factors, we do see that there's minor gonadal hormones that can influence gender identity and sexual orientation. This really develops in the prenatal or early neonatal development. There could be underlying genetic, endocrine, fetal exposure that can really shape a person's gender identity. They've also done MRI studies that have shown minor structural differences in patients who have gender dysphoria. And we'll get into that in a little bit. But a lot of the data we have is inconclusive. Additionally, a lot of it's based on this case of David Reamer. I'm going to go into David Reamer for a little bit. So David was born a boy. He was actually a twin in the 1960s. And he and his brother went in for a circumcision. Unfortunately, the circumcision didn't go as planned, and David's external genital organs were burned. His parents then decided to raise David as a girl. He dressed in dresses. He played with dolls. They gave him estrogen therapy to help with breast formation. However, at a very young age, David really never felt like a girl. He began telling his parents that he felt like a boy, that his twin brother, he was his brother, not his sister. At about age 14, David's father told him there was actually born a boy. And what happened? David then began to transition into a boy fully. He did many talks about his experiences. Unfortunately, David ended up committing suicide at 37 years old, really due to a lot of mental health issues that occurred. And David's situation, while it's unique, his struggle with his gender identity isn't. Many transgender and gender nonconforming patients experience a lot of these same things, and leads to really poor health outcomes. So many of them may have gender dysphoria, which I'll mention in the next couple of slides. A lot of them are worried about stigmas. So stigmas could be interpersonal stigma. This is discrimination, hate crimes, judgment, bullying done by other individuals in the community to the TGNC patient. Because of that, a lot of these patients develop intrapersonal stigma. This is also known as self-stigma. It's negative attitudes from the public about a person's specific characteristics. Those negative comments are then internalized, and the patient begins to develop low self-esteem, poor self-efficacy. And lastly, there's structural stigmas. So these are cultural norms that are put by an institution. It's laws that really shape inequality in both power, resources, social capital even. TGNC patients feel a lack of support many times, particularly in the medical community, where they feel that doctors, pharmacists, healthcare professionals may have a bias against them and don't really have the knowledge to treat them. Because of that, they either treat themselves or they resort to substance abuse. Compared to the general population, the TGNC individuals are 2.5 to 4 times more likely to use hazardous alcohol. They're also 2 to 2.5 more likely to use illicit drugs in their lifetime. Because that, a large number of patients are diagnosed yearly with HIV due to sharing of needles. These patients are 2 times more likely to report recent 30-day prescription pain medication use, and are 3 times more likely to smoke cigarettes. There's also a higher rate of depression, suicidality, self-harm, eating disorder, compared to any other sexual minority group or their cisgender counterparts. In 2021, a census was done by the National LGBTQIA Task Force and National Center of Transgender Equality. It surveyed a little under 6,500 TGNC individuals. 90% of them reported harassment or mistreatment on the job. 26 stated that they lost their job due to defining as transgender. And 53% have been verbally harassed in a place of public accommodation. Now, a lot has changed since 2011. We now have laws preventing discriminations on the basis of gender and sexual identity. Many of these laws in the last 5 years have been repealed. So there's definitely a need to really understand what these patients are going through today. More data from that survey. 33% have delayed care due to discrimination. 50% report having to educate their medical providers about their needs, which is not something you hear often, right? When a patient comes in for diabetes, the patient really isn't educating their provider on how to treat their diabetes, right? But for transgender care, many of them feel that they have to tell the doctor what they need and what their goals are. 28% will report discrimination and have postponed care because of the fear. 48% just can't afford medical care. 19 have been refused medical care, and 30 report having some kind of disability or mental health condition. So let's go into this idea of gender dysphoria that I mentioned a little earlier. So in 2013, when the DSM-5 came out, they actually added gender dysphoria as a mental health condition. So gender dysphoria was defined as a discomfort, distress, or functional impairment caused by the incongruence between assigned gender and affirmed gender. Previous to the DSM-5, they had a diagnosis of gender identity disorder. So that's when the DSM-4 was still out. Currently, that diagnosis is no longer accepted by the TGNC community. So with that, it leads into my first assessment question, which please write in the chat. True or false? All transgender and gender non-conforming patients experience gender dysphoria. All right, excellent. So majority of you got it. So it's false. Not everyone who identifies as a different gender has gender dysphoria. There must be some level of distress or impairment to diagnose this disorder. And the symptoms have to persist for 6 months. So I've listed here the 6 characteristics the DSM-5 uses to diagnose gender dysphoria. A patient has to have 2 of the 6. For the purposes of time, I won't read through them, but I do want you to be aware of them. That being said, unfortunately, diagnosis facilitates access to care. And without that, many insurance companies will not cover TGNC care. An ICD-10 code of F64.9, which means gender identity disorder, is needed for insurances to pay for gender affirming therapy. Again, this is an old diagnosis from the DSM-4 that's no longer used today in the DSM-5. However, it still is needed for for insurances to pay for gender affirming care. Documentation of a mental disorder, even gender dysphoria, can be triggering for many patients. This is often linked to historical stigmas that they may have faced, or this idea of mental illness that the patient doesn't have. Thankfully, you don't need a diagnosis code to start hormone therapy, but for other medical transitions, you do. The goal of gender affirming therapy, though, is not always to fully transition to the opposite gender. And we're going to go over that in a little bit, but it's not always to go from one side of the line to the opposite. It may be used to go somewhere in between, and we have to adjust our medications accordingly. There's 2 types of transitions. There's social transition, and then there's physical transition. So social transition is changing gender behavior to reflect their affirmed gender. This is specific to cultural or societal understanding of gender norms and doesn't have to be in every environment the patient's in. So the patient may socially feel comfortable dressing a certain way while they're out with their friends, but dressing a completely different way at work because they're afraid of that stigma. Social transition can also be using a gender affirming name, using gender affirming pronouns, using a suitable restroom that's based on their affirmed gender and not their assigned gender, or even assuming social roles of their affirmed gender. Now, it's a little different than physical transition. So physical transition is an actual mental intervention to change sex characteristics to reflect their affirmed gender. This could be hormone therapy, surgery, even non-medical interventions like laser hair removal or voice training. Physical transition is often in collaboration with their patient's primary care doctor, endocrinologist, mental health professionals, surgeons. Hormone therapy could be used to receive a more feminizing or masculinizing body, or change primary or secondary sex characteristics, things like breast, genitalia, face, body contouring. Now, the goal of pharmacological therapy, which is what we're going to focus the rest of our presentation on today, is to induce a physical change that's more congruent with the patient's gender identity. Now, we have to individualize a patient's goals. So not every patient's going to have the same goal. Some patients, we might want to maximize masculinization or feminization. Some patients, we might want to minimize masculinization, feminization for a more androgynous appearance. For our feminizing hormones, primarily we use estrogen and androgen blockers, while for our masculinizing hormones, we primarily use testosterone. Currently, as pharmacists, we've been taught to follow guidelines. However, currently there's no major medical society that publishes standards of transgender care. The Endocrine Society does have a few recommendations, but not a complete guideline yet for the treatment of these patients. Treatment regimens are mostly anecdotal, so they're based on observational studies that doctors may have treated patients with. Many of what we have available now are recommendations made by, unfortunately, white cisgender males who have very limited experience with the transgender community, or their struggles at that. Hormone therapy, often when speaking to transgender patients, is dosed by older transgender individuals in the community. These patients really have little to no formal education, and that's been going on for generations. Patients may come in and say, I know what dose of hormones I need. My friend went through the same process, so I know what I need. And that's kind of been the standard of care for a very long time with these patients. The problem with that is side effects, adverse reactions, patients don't really know about. And they also don't know how to monitor for these hormones as well. So that's our job. That's where we come in. The guidelines that are available, there's 3 that I'm aware of and that I use. So the first one is WPATH. So the WPATH is specifically designed for implementation on a regular day-to-day basis in healthcare settings. They also have recommendations for settings with very limited resources. The University of California, San Francisco also has guidelines. These take the WPATH guidelines and actually add more anecdotal information on them. And then Transline. So Transline is modeled after the 2 guidelines I previously mentioned. What's nice about Transline, it actually has dosing equivalencies. So when we're transitioning patients from oral, maybe to injectable therapy, it has a proper dosing equivalence to it. Historically, to initiate hormone therapy, letters from more than 2 providers are needed. Now, these are stating that the patient wants to start hormone therapy for a full calendar year and their assessment of readiness. So readiness is defined as a persistent, well-documented gender dysphoria, again, a medical disorder per the DSM, capacity to make informed decisions and consent to treatment, age of majority in a given state, so in New York State, that's 18, and if significant medical or mental concerns are present, they have to be controlled. Now, the idea of readiness, and I really want to drill this in, is still used today as an excuse to not provide gender-affirming care. To me, and to many of you when we talk about medications and disease states, readiness is anyone who really wants to start therapy, right? You're not going to hold, back to our diabetes example, a medication for a patient's diabetes because for whatever reason, right? If the patient's ready to start therapy, we start therapy. Our job really is to counsel these patients on realistic expectations of hormones, risk versus benefit. We don't want to be this hormone gatekeeper that says you haven't wanted it for a full calendar year. At the end of the day, if you deny someone therapy, they're going to get it if they want it. So they'll get it from the streets. By properly assessing if a patient really is informed about how to start these therapy, we're preventing really inappropriate dosing of these medications. You're not preventing transition by waiting a full calendar year or worried about the patient might change their mind. No, you're preventing them from receiving adverse effects from these medications and dosing themselves inappropriately. So WPATH still uses this readiness model. What other guidelines or what other recommendations are really using is this idea of informed consent. So we inform the patient of the risk and benefit of hormone therapy, evaluate their mental capacity to make informed decision, and lastly, we set realistic and attainable goals for that patient. For many patients, again, when we talk about androgynous appearance, we might not want a high dose therapy. We might want low dose hormone therapy. Some patients' goal may be they just don't want to look like either a boy or a girl. Okay, and that's okay. And we have to dose the medications appropriately. So finally, let's get into our feminizing therapies. So our main one here is estrogen. It suppresses or minimizes male secondary sex characteristics and develops female secondary sex characteristics. We also have our anti-androgen agents. These are our T blockers. So they directly inhibit testosterone secretion and androgen binding to the androgen receptors. And last, we have our gonadotropin releasing hormones. They block the release of FSH as well as LH. So there are three naturally occurring human estrogens, known as E1, E2, and E3. E1 is estrone, E2 is estradiol, and E3 is estriol. E2 is the principal intracellular human estrogen. It's more potent than estrone or estriol at the receptor level. What's important is that estrone, E1, levels are higher in the early development of breast bud formation in cisgender females. We've learned that oral estradiol actually results in higher serum levels of E1, and that's mainly due to first-pass hepatic metabolism. So I've listed here for you the main four estrogen therapies that are available on the market today. I've listed the initial dose as well as their max dose. Again, the dosing is based on the patient's specific goals. So our injectable therapies can be used once weekly, maybe once every 2 weeks even. We have our transdermal, which is given bi-weekly. Just keep in mind the max dose of this. I'll go into it in a second. The max dose of our transdermal options are 0.4 milligrams. We also have our oral estradiol, which can either be PO or even sublingual. This is given daily to the patient. Kind of going into the pros and cons of these regimens. Our injectable therapy, we use it less often, right? We have to administer once a week, every 2 weeks. So that might be comfortable for a patient who doesn't want to take daily pills. It avoids first-pass metabolism, and it may better suppress endogenous hormone production. However, it is an injection, which is uncomfortable for certain patients, and there is a fluctuation in levels due to peak and trough of these injectables. We then have our transdermal options, so there's less fluctuation in levels when compared to our injectable agents, and just like the injectables, there's no first-pass metabolism. Unfortunately, they are expensive, and the max single patch dose is 0.1 milligrams. So in the last slide, I mentioned that the maximum dose could be 0.4. So these patients might have to use 4 patches to get the proper dose, which is really uncomfortable for the patient to use. We also have our oral therapy. So there's less fluctuation levels compared to the other two. However, it does go through first-pass metabolism. They have to take it daily, and sublingual may actually be TID dosing, so 3 times a day. So when I spoke about how do we know what dose of therapy, a lot of it is really based on the expected onset of effect. So we really want to look at what the patient's goals are. So I've listed here for you when patients should expect some kind of change versus when they should have maximal benefits. So we see something like breast growth really occurs in 3 to 6 months with maximal effect at 2 to 3 years. Now, breast growth is one of these things that unfortunately is permanent. So once they start therapy and they begin having breast growth, that's not reversible. Other things that may be permanent, male sexual dysfunction, so decrease in sperm, reduction in fertility, decrease in testicular volume, these are also likely permanent. Everything else is reversible. But again, you want to have our patients understand how long it takes for them to reach maximal effect. This isn't an overnight thing. This isn't even a month or 2 month thing for most of these cases. This could be years of therapy. And patients have to be aware of that as well to set their unique goals. So there is a lot of controversy with whether or not we monitor therapy. For the most part, when we're starting feminizing hormones, we're going to monitor estrogen, or estradiol rather. Really, the reference range, and again, this is very depending on which guideline you look at, is about 100 to 300. The range was given from estradiol levels in really pre-puberty cisgender females. In many patients, if they don't achieve their target E2 ratio, we want to check E1 to E2. So in an ideal world, the E1 to E2 ratio should be 1 to 1. but many times the max, it should be 3-to-1. Sometimes it's a little higher. And if it is higher, we might want to switch to an injectable formulation. Why? Because injectable formulations actually favor E2 metabolism because there's no first pass effect. There's also testosterone and prolactin levels. We really don't monitor them too often. A big reason we do want E1 though, and I mentioned this a little bit earlier, is for that breast bud formation. So maybe in the beginning, we might want higher levels of E1. But later on, to achieve other effects, we do want an equal ratio of E1 to E2. Okay, and that's where we might switch patients from oral to injectable. So this is a dose equivalency that was from Transline. Again, when we're switching patients between therapies, this is the dose equivalency chart. This is for your reference, of course, but really nice that this resource does exist. There is a lot of thromboembolic risk when it comes to estrogen therapy. Transgender patients, females rather, taking estrogen are at high risk for a VT. We know that. The risk really depends on the formulation, the dose, as well as the presence of other risk factors. So think of things like tobacco use, previous history of other VTEs, comorbidities the patient has. There is a PADUA risk assessment that does account for ongoing hormone therapy. However, for my ambulatory care pharmacist, or really any pharmacist that's working with patients who have atrial fibrillation or with anticoagulation, it's unclear at this point if we add an additional point to females when we're calculating CHADS-2-VAS. Really, this is based on clinical decision. So how long is a patient been on therapy, really? What are their other risk factors? We have also anti-androgen blockers, also known as T blockers. So the main one here is spironolactone. Pay attention to the dose here, because this is not the dose we normally see on spironolactone. Our starting dose is 100, while our maximum dose is 400. Because of that, there is a risk for hyperkalemia and a diuretic effect as well. What we do want to know about spironolactone is we want to start estrogen therapy first, particularly oral estrogen therapy. Why? Is because spironolactone actually reduces breast development due to premature breast bud fusion. So we want the patient to first be on estrogen therapy. After that, we'll add on spironolactone. You never want to add them on at the same time or spironolactone first. There's other agents as well, finasteride, dutasteride. This is really to prevent balding. They could also be used adjunctively to spironolactone if a patient can't tolerate spironolactone or if it's contraindicated for spironolactone. What's interesting is also you can use dutasteride and finasteride together. So you could actually give dutasteride every 3 days for an additive effect. Lastly, we have our puberty blockers. These are really used in the care of peripubal transgender youth who require pubertal delays. Guidelines will recommend initiating them on the first signs of puberty and then stopping them once cross-sex hormones are initiated. It can be used in adults who aren't achieving goals with hormone therapy. However, there is a significant bone density loss with prolonged use. Thus, they're really not recommended for adults or for long-term use as well. But they're listed here for your information. We also have to be aware of non-pharmacological approaches. So the first one is tucking. So tucking is the idea to obtain a more feminine genital appearance before or instead of surgery. So the testes are put into the inguinal canal, the penis and scrotal are placed in between the legs. Why I'm really mentioning this is us as healthcare professionals have to be aware that there is a lot of neuropathic pain and infection that can occur if a patient is tucking. So those questions need to be asked when evaluating the patient. There's also voice therapy by a trained speech language pathologist to achieve a more feminine voice. And there's surgery. So these are feminizing surgeries, vaginoplasty, penilectomy. If we're looking at breast surgery, it is recommended to be on hormone therapy for at least 2 years before initiating breast surgery. Really, this is for that breast bud formation. So before we finish with our transgender females, I do have an assessment question. So we have MJ. She's a 56-year-old transgender female with a past medical history of hypertension and tobacco use. She's been on hormone therapy for about a year, comes into your clinic today for a follow-up. So her medication, she's on aspirin, spironolactone 300, she's on chlorthalidone for her blood pressure, and then she's on estradiol 4 milligrams daily. We got her estradiol levels, and it's about 500 to 50, also 1 to 10. And then her testosterone and prolactin are normal. So she's concerned she's not really getting the results she expected. So based on MJ's labs and goals of therapy, what is the best option for MJ at this time? You can write it in the chat. So we got a few answers. I'm gonna wait for a few more. Excellent. Really, majority of you got it as well. It's to discontinue oral estrogen and initiate IM estrogen. Why? Because one, the E1 to E2 ratio is higher than 3 to 1. So we're going to avoid the first pass effect by initiating IM therapy. Plus, it's going to give her better results at the end because of the expectations of IM and the E2. We then have our masculinizing therapies. This really is testosterone. There's a lot of formulations of testosterone, injectable, gels, patches, creams, even once monthly, and then every 10-week injections. Again, I've listed for you your low doses, kind of your typical dose most patients are on, and then the maximal dose as well. So just like injectable estrogen, there is a peak and trough disparity with our injectable testosterone. What's nice is it's less frequent, and actually the peak may better suppress endogenous therapy. But this is a self-injection. And if a patient can, they really have to frequently go to the doctor's office to get it injected. There's also our topicals, so our gels or patches. These have less fluctuation in levels. They're also good for a more gradual effect. What's not so great is that they actually they may be slower to stop menses and really may not fully stop them at low doses. There's also a risk of transferring these agents to pets or other partners. It's daily application and it's expensive if the insurance isn't covering it. Our last one is our testosterone that's really given monthly and then every 10 weeks. I really haven't seen this one covered very much by insurance companies, unfortunately. So just like our feminizing therapies, we do have to set realistic expectations for our patients. So again, these take anywhere between 1 month to see some effect to 5 years to see a maximal effect. There are things that are permanent. So facial hair growth is permanent, deepening of the voice, as well as clitoral enlargement. The big one we really look for in masculinizing therapy is cessation of menses. So this should occur within 6 months. And if it doesn't, we really have to advance therapy. So that's kind of our go-to effect that we want to see in all patients who we initiate on testosterone for masculinizing therapy. Just like cisgender, just like transgender females, transgender males, we use the cisgender reference ranges, and we really monitor total testosterone levels. So again, the levels range based on what guideline you're looking at, anywhere between 400 to 1100. Really, the only time we won't target these levels is in the setting of any undesirable effects. And as I mentioned before, clinical response is the presence of cessation in menses by month 6. Testosterone levels are actually really, really difficult to measure, even in cisgender males, because there's a rapid fluctuation in levels. The testosterone level in the morning is not the same at night. Actually, cisgender men produce more testosterone in the morning. And this is really related to the release of the gonadotropin. This is not the same for transgender males. So when we're monitoring testosterone levels, we really want a mid-cycle reference to use. It's often sufficient unless the patient's experiencing cyclic symptoms. These are often migraines, pelvic cramps, mood swings. In that case, we obtain a peak and then a trough, and then check for the fluctuations. If our patient has these cyclic symptoms, we can actually consider switching them to a transdermal preparation or reduce the injection interval. So transdermal is really the way to go if our patient has any type of these side effects that are really unpleasant. we don't really monitor estradiol levels. Only time we will is if the patient has these adverse reactions. Special considerations, we do want to really educate on mental health. There is a risk of cancer when starting hormone therapy. PCOS, we want to monitor for, and then alopecia, just like our transgender females, we can always give finasteride or dutasteride. Polycythemia is a risk when we're looking at testosterone therapy. So this is usually patients who are taking testosterone and their hematocrit is greater than 55%, increasing their risk for hypertension, thrombosis. We want to rule out any type of pulmonary disease. And if polycythemia is secondary to testosterone, we want to consider changing the interval schedule, switching to transdermal, or doing therapeutic phlebotomy. Of note, transgender patients are not allowed to donate blood for the FDA. So that blood, unfortunately, would go to waste. And we want to check labs every 1 to 3 months after changes are made. Non-pharmacologically, we have breast binding to create a more flatter chest appearance. Patients may wear sport bras, elastic bandages, duct tape. Again, we want to be aware of risk of infection, risk of pain as well. And then surgery. There's mastectomies, there's also bottom surgery as well. So this leads me to my third assessment question. So we have AK, a 52-year-old transgender male, past history of diabetes, PCOS, tobacco use. He's been on hormone therapy for about 6 months, comes into your clinic for a follow-up. So he's on metformin, he's on injectable testosterone 50, he's on atorvastatin and aspirin. His testosterone was 1,000, which is at goal, the higher end of goal, but still at goal. And his hematocrit's 54, so it's right there, almost at 55. So AK reports experiencing headaches and pelvic cramps since his last visit. So based on his presentation, what would be the best option for him at this time? I'll give everyone a minute to write in the chat what they think is the best answer. Excellent. So the correct answer here is switch from IM to a transdermal option, right? To really get rid of those cyclic symptoms that the patient's experiencing. So a big question I get asked often from our pharmacy, even our pharmacy students, is how do we calculate creatinine clearance for transgender patients? So really the effects of gender-affirming hormone therapy on renal function and ideal body weight is still really unknown. We have a few studies that we'll go into, but they're very small. Really, there's a huge difference in fat, muscle, plasma volume between these genders. When we look at our creatinine clearance formula, right, we really base it based on gender. And it's unclear which formula is best to use in transgender patients. So LaPaw actually looked into this a little further. It was a small observational cross-sectional study of transgender women and cisgender men. So it was used to assess body composition and body mass, and then look at serum creatinine as well. Transgender women must have completed gender affirmation surgery at least 3 months prior and been on estrogen therapy for 2 years. So quite a significant amount of time. What the study saw is that lean body mass did have a significant difference between our transgender women and our cisgender men. And so does serum creatinine. So the authors conclude that biometrics more closely resemble the patient's gender identity than their assigned gender in transgender women after prolonged hormone therapy. So this case, 2 years plus surgery. Gitte and colleagues also did a study. This one's actually a prospective trial that looked at lean body mass, serum creatinine prior to, and then only 4 months after gender affirming therapy. It took 17 transgender females and 17 transgender males. So in the case of our females, they were treated with estradiol in combination with cyproterenate acetate. For those that are unfamiliar with that, it's not available in the United States, but that's the androgen blocker that is used in Europe and other parts of the world. And then transgender men were treated with testosterone. We look at our transgender females, we really didn't see too much of a change in body mass, but there was a change even after 4 months in serum creatinine. In men, we saw a difference in lean body mass and serum creatinine after just 4 months. So the authors concluded after 4 months of hormone therapy, serum creatinine more closely reflected affirmed gender rather than assigned gender. Using these two studies, In 2022, AJHP actually released an article on how do we properly assess serum creatinine and ideal body weight in transgender patients. It recommended that if a patient's been on therapy for less than a month, we're going to use their assigned gender for both. If a patient's been on therapy for less than 6 months, we can really consider using assigned. Really, this is based on the dose of therapy that they're on. But if they've been on therapy for 6 months or greater, we're going to use ideal body weight and serum creatinine based on their gender identity and not their assigned gender. With that, let's go into my last assessment question. So we have BB, a 30-year-old transgender female, has been on hormone therapy for 12 months, and you're calculating her serum creatinine. Which formula are you using? All right, great job. Everyone's killing it with the answers today. So the answer is B. We're going to use the female serum creatinine clearance formula. Preventative screening, I listed here really for your information. What I want you to recognize with preventative screening, really, if a patient has the organ, we're going to screen it. That's really all we need to know about preventative therapy, regardless of how long they've been on hormone therapy. So if a patient has a prostate, we're going to routinely screen the prostate. If the patient has breast, we're going to screen them. So to really kind of conclude my presentation, a pharmacist's role in transgender care is to be aware of the transgender and gender non-conforming needs of the individual space, provide a gender-affirming experience, and troubleshoot how we really record assigned gender versus affirmed gender in our electronic medical record. What's nice about Epic, which is the system I use at Coney Island, is that we can actually write gender at birth versus gender identity. We want to make sure patients are properly vaccinated, especially now, properly dose these medications for our patients, and assist in preventative measures. And lastly, and most importantly for us pharmacists, medication education. I've listed here for you some resources that can be used. There's also consent forms, examples of letters for insurances at these websites. Great places to really go if you need further education or if you need any type of examples or literature. In conclusion, it's important to recognize terminology used by the TG and NC community. Understand their physiological differences, the differences between cisgender versus transgender individuals, and that could aid in proper medication therapy. It's fundamental to set realistic expectations with regard to gender-affirming therapy. Let our patients know what their goals are and when they might achieve those goals. And then lastly, address the unique needs of this community. By that, we're not only improving the lives of them, but we're ultimately improving the lives of our entire community. With that, I'm going to take any questions you may have. Thank you so much.
Thank you very much, Dr. Gerber. We do have a few questions in here. One of the questions is, what contraception preferences have you seen with transgender males, or is this individualized?
So contraceptive in the sense of estrogen therapy, they do use it. Again, we're not really going to monitor estrogen levels in these patients, but there are low doses of really birth control that can be used that won't really affect patients' testosterone levels. The really only time we're going to worry about it is if a patient has side effects. So if a patient's having cyclic symptoms, then we really want to monitor it and then discuss risk versus benefit of continuing this. Or should we use another kind of barrier method for contraception?
Okay, I'm going to ask one more question, sorry. How do you address some of the social determinants of health that also affect your patients in terms of access to care and adherence to care?
So that's a hard one. It's a really loaded question on how do we properly address their social determinants. The way I do it is education to all providers. So this presentation isn't just something I give to kind of NYSCHP, but it's educating all providers on the roles and the kind of inequalities that the transgender community has. After that, there are different at least in my facility, there are nurses, there are care managers that would reach out to patients if they've kind of fallen off the map or we haven't seen them for a long period of time. Really, a big thing with this community is the distrust of providers. So when they meet you the first time, if you start that gender affirming experience, they're more likely to visit you and see you. So that's kind of how I've really tried to kind of combat these social determinants and really get patients to feel welcome when they see me, and that I'm here as a provider, not only for whatever their needs are, but also to figure out how they are as individuals. Because once we tackle a patient's kind of psychological needs, we can also tackle their medical needs. I hope that answered the question, because it's a pretty difficult question.
I think we have time for one more question. This question is, for every 10-week or long-acting testosterone injections, how do you handle it if an adverse effect or outcome occurs?
Great question. So for the 10-week one, we started every month. We give it once a month. Usually at that point, we'll see side effects develop fairly quickly. And then we switch, if they do, we switch off to the once weekly injections. We don't do the every 10-week injection unless the patient's really tolerated monthly injections first. So we really assess it. Unfortunately, I haven't seen a lot of use of the really long-acting monthly 10-week injectable because insurance is very rarely covered. So they have to have probably tried weekly injections first, tolerated it, and then we switched off. And if they didn't tolerate the monthly, then we switched back to the weekly.
Thank you so much, Dr. Gerber, for today's webinar and for answering the questions as well. Just to wrap a few things up, the CE code for this program will be patient